Hi everyone, welcome to the Eyeli app. My name is Ilse Homan, and in this video we're going to go through a basic binocular vision assessment using the Eyeli app. We are all spending more time on near digital devices at a higher visual demand than previous generations, and the latest research over the last few decades is showing a general increase in the incidence of eye strain and non-strabismic binocular vision dysfunctions. But why is this happening, and how can we assess this? Our eyes are physiologically built for predominantly distance viewing, where our eyes are pointing straight ahead and accommodation is relaxed. This requires a low visual demand. But the moment we look at any target at near, our eyes have to turn in, and the lens inside each eye has to accommodate. This requires effort from the muscles in and around the eye, or a higher visual demand. And as with any other muscle in the human body, if we overexert a particular muscle, it could end up spasming or underperforming due to exhaustion. Looking at a near target also requires more effort from the brain to point and focus the eyes correctly, to be able to fuse the two images from each eye into one single clear image with depth. We can measure the efficiency of a visual system and its muscles by doing a basic binocular vision assessment, where we assess the convergence and accommodation systems. And for each of these systems, we want to measure its accuracy, that is, how accurately the visual system is aligned or verged and focused or accommodated onto the target we are looking at. We also want to look at its range. What is the total capacity? How strong is the system? We want to measure the most amount of work or output the system is able to generate. Here we want to see just how much vergence in and out and accommodation power the system is able to produce. And lastly, we want to look at its flexibility. How quickly can the visual system accurately switch between different target distances, for instance, distance and near? To do a basic vergence assessment, we measure the accuracy and the range. And when we assess vergence accuracy, we look for the presence of any tropias, phorias, or fixation disparities. If a patient walks in with an apparent squint, it is easy to see that there is a tropia. But if not, a quick cover test will tell us whether there is any misalignment and whether that misalignment is a tropia or a phoria. The cover test is a manual test, and to perform it we need an occluder and a fixation target. This could be anything interesting for the patient to look at 40 centimeters. The patient is going to look at the fixation target whilst we cover one eye at a time, while we look for any eye deviation or eye movement in both the eye that is not covered as well as the covered eye when we uncover it. If we cover an eye and the uncovered eye moves, we have a tropia. If that eye moves out, it means that that eye was too in, and it's an esotropia. If that eye moves in, it means that the eye was too out, and it's an exotropia. We cover each eye, right and left, a few times, checking the uncovered eye, and if there's no movement or atropia, then we look at the covered eye. If we lift the cover from the covered eye and that eye moves, we have a phoria. If that eye moves out, it means that it was too in, and it's an esophoria. If that eye moves in, it means that the eye was too out, and it's an exophoria. To record the findings, note whether it is an ortho, atropia, or a phoria, and whether the deviation is ESO or exo. To measure the magnitude of the deviation, regardless of whether it is atropia or a phoria, we use the fusion cross Eyeli test. For this test, the patient is going to wear the red-green anaglyphs to dissociate the two eyes. And we ask the patient to put the green circle in the center of the red cross, or to align the two targets. This will measure the size of both the horizontal and vertical deviation, if any is present. To check if there's any fixation disparity or associated phoria present, we use the fixation cross Eyeli test. The patient is still wearing the red-green anaglyphs, similar to the fusion cross, but the target now has a fusion lock, a part of the target that both eyes can see and fuse, even though both eyes can't see the green circle and the red cross. This brings the two targets close enough to fall on corresponding retinal areas of both eyes, which makes it easier for the brain to fuse, but not close enough to fall on corresponding retinal points. So the eye still has to do some work to fuse the two targets perfectly. If we don't get an ortho here, we know that even if both eyes are open and the patient only sees one target, so there's no double vision, there is still a slight misalignment. This is a system that could see single, but is straining. The distance phoria can be measured in the phoropter doing the Maddox rod test by selecting the spot on the VA chart and putting both the Maddox horizontal red lens, which will give you a vertical line, as well as the Prism dial in front of the right eye. I like to start the test with the Prism dial on 12 base in, or towards the nose, because then usually the patient will see a white circle and a red line, and adjusting the Prism dial closer to 0 will move the red line closer to the white circle. If this makes the line move further away from the circle, stop and adjust the dial to move in the opposite direction. We are going to ask the patient to help us align the circle and the red line. And we're going to stop when the red line is going through the center of the circle. Record where the patient sees the two targets as aligned. Is it at 0 or ortho? Is it still on base in, where the arrow is still on the nasal or inside of the 0? Or is it at base out? Is the arrow on the temporal or outside of the 0? And what is the amount? To assess the Vergence range, we first measure the negative fusional reserves or divergence, and then the positive fusional reserves or convergence. And we can do this by either measuring it manually with a Prism bar or doing the Eyeli Vergence tests. If we do the Prism bar test, we will need a Prism bar and a fixation target. Again, this could be anything interesting for the patient to look at 40 centimeters. Most Prism bars has the base on the left side of the bar. Thus, putting the bar in front of the patient's left eye measures divergence or base in to break, and putting it in front of the patient's right eye will measure convergence or base out to break. The nice thing about the Prism bar test is that we can measure vergence either subjectively by asking the patient to report when they first see two targets or double vision, or objectively by looking at the fusional reflex, which is the compensatory eye movement to keep fusion. We start by having the patient look at the fixation target at 40 centimeters. We then put the lowest amount of prism on the bar, the top prism, which is normally 1 diopter, in front of the eye. We are systematically going to move through every single prism on the prism bar by slowly moving the prism bar up, prism by prism, increasing the Vergence demand, each time asking the patient if the target is still single and checking the compensatory eye movement. With divergence, or base in, with every increase in prism, the eye will have to turn out to keep Vergence or fusion. When we get to the higher base in prisms on the bar, we are expecting the eye to be noticeably diverged. When we then go, for instance, from 16 to 18 base in, we expect the eye to diverge out a little bit more, as with every prism step, to maintain fusion. If, however, the eye jumps around, or even reverse back in, we know that the patient is no longer able to maintain fusion. And the previous prism, the last prism where the patient was still able to maintain fusion, in this case 16, is the value we record on the Eyeli consultation form. When a patient is really young, or unreliable, or have a suppression, this way of objectively measuring fusional range becomes very valuable. With convergence or base out, with every increase in prism, the eye will have to turn in to keep fusion. We can also measure Vergence range with the Eyeli Vergence tests. For this test, the patient is going to wear the red-green anaglyphs to dissociate the two eyes. But instead of using Prism, we are physically going to displace two identical targets, one set of red and one set of green circles, to force the eyes to diverge or converge in order to fuse these two images. The test starts with the two targets aligned, so no displacement. But then with every subsequent slide, the red circles and green circles are going to be displaced further and further apart, increasing the Vergence demand. With each slide, we're going to ask the patient how many circles they see to check if they can still fuse. For instance, in this slide, if the patient is fusing, they will see only 2 circles, in which case you press yes. If they are not able to fuse, they will see 4 circles, in which case you press no and the test is over. Again, we do divergence before convergence. And the convergence test works in exactly the same way. Again, we see if the patient can fuse the images and then press yes or no. To do a basic accommodation assessment, we measure the accuracy, the range, the flexibility, and lastly, relative accommodation. We measure accommodation flexibility with the Eyeli accommodation flexibility test. We will need a +2 -2 flipper to relax and stimulate accommodation, as we ask the patient to identify the letter or shape on the screen. If they are correct, we select yes, and if they are incorrect, we select no. This test will automatically show a new character each time you press yes or no, and run for 1 minute to measure the total amount of cycles per minute. We measure accommodation accuracy to determine if the focus point is accurately on the back of the eye when we are looking at a near target. or whether there is a lag or a lead of accommodation. We can measure this by either doing MEM Retinoscopy or the fused cross-cylinder test. MEM is a form of near-point retinoscopy, where we measure the accommodative response. For this test, we will need a retinoscope with MEM cards attached to it, and loose lenses or flippers. I made myself a set of 3 flippers specifically for MEM. One set with a plus 050 and a plus 1. One set with a plus 150 and a 2. And the last one with a plus 250 and a plus 3. We hold the retinoscope with MEM cards 40 centimeters away from the patient's eyes and use the loose lenses or flippers to neutralize the patient's reflex while they name the pictures or read out the words. We look at the ret reflex movement. If we move the light from left to right and the response is neutral, we don't have to add any plus or minus lenses. If we get a with movement, we need to add plus. And if we get an against movement in the pupil, we need to add minus. Start with no lenses. And if you see a with movement, you have to add plus. Then put the plus 050 in front of both eyes. If you now see an against movement, the add is plus 0.25. If the reflex is neutral, the add is plus 050. And if we see a with movement, we then go to the next lens, which is the plus 1 in front of the eyes. The fused cross-cylinder test is a manual phoropter test. We start by occluding both eyes and putting the cross-cell lenses in front of the patient. When you open the eyes, you're going to ask the patients which lines are darker, clearer, or looks closer to them, vertical or horizontal. If the answer is horizontal, add plus in 0.25 steps until the response is neutral, or the vertical and the horizontal lines are equally dark. This is the desired outcome. But if the patient don't have a neutral and jumps straight to vertical best, we're going to record the last lens that gave a horizontal best. For the relative accommodation tests, I like to use a numbered chart with letters or shapes to double check if the patient can really see the target when I add plus or minus. And I always do plus to blur and then minus to blur. With negative relative accommodation, where you relax accommodation by adding plus to blur. Because we do this at 40 centimeters, which requires a plus 250 of accommodation, if we get more than plus 050, we know that we've either over minus the patient or the patient is a hyperope, because we can't relax more accommodation than what is needed at a specific distance. With positive relative accommodation, where you increase accommodation by adding minus to blur, because we do this at 40 centimeters, we measure the total amount of accommodation that can be produced over and above the 250 that is already produced to see at 40 centimeters. Therefore, if we add plus 250, we have the total amplitude of accommodation if we use the minus lens method. If we want to determine if the convergence and accommodative systems are working well together, we can look at the ACA ratio. Here we measure the total amount of convergence in diopters induced for every diopter of accommodation that is needed. The closer the object we look at, the more our eyes have to accommodate and converge, and these two systems need to be in a specific balance at all distances for for us to maintain single, clear, and comfortable vision. This perfect balance, the gold standard, is a ratio of 4 to 1, but the norm is anywhere between 3 and 5 to 1. If the ratio is over 5 to 1, it is high. It means that there is more convergence produced per unit of accommodation than the norm. If the ratio is less than 3 to 1, it is low. It means that there's less convergence produced per unit of accommodation than the norm. Apart from interpreting and comparing all our results to the latest peer-reviewed normative data and automatically calculating the ACA ratio for you, Eyeli will also compare your results to the latest classification criteria for non-strabismic binocular vision dysfunctions to help you identify possible suspects. All of this information can then be used to determine if the patient has any binocular issues or even non-strabismic binocular vision dysfunctions. Technology and digital screen time is becoming a part of everyday life, and as optometrists, we have the ability to better equip our patients for this new visual demand, to prevent or treat binocular vision problems that can lead to visual discomfort and eye strain, and can interfere with attention as well as work and academic performance.